there anything you guys can think of that I can do to make this less painful for you, but a more learning environment? Please let me know, okay?
For the final, will there be any kind of review, main points, to make sure that we get covered, or?
I can do my best to give you prompts and review stuff. I've tried to do that along with the different things I've done, and I will do my best to do that as well. Now that, if they let me see the final. Everything's about access, baby.
Is there a reason why? Because I feel like using it before teaching class will give you a clue on things.
Amen. It's been my argument.
Last lesson, she did give us things to pay more attention to. So,
Okay.
I'm pretty sure
She'll let me do it too. Okay. That sounds good. But
it wasn't specific.
that's exactly what I
It was a
did.
whole list of stuff, but it
Oh.
helped.
Because I feel like even like last semester, everybody that's been here already, all the previous teachers, they already know the test, and when they're teaching, they prompt you on things
Right.
to pay attention.
Exactly. Exactly.
So I feel like it's wrong for the new teacher not see it until the test, because
I'm in agreement.
They're on trick
I feel
service.
they're setting you up for failure. Seriously, that's what it sounds like. Because
I'm glad it's not just me that feels that way. Oh, man. Like I said, it's been painful. But you know what? Even this painful is not as painful as where I came from. It's still much better. You guys are much kinder. I think one of you guys saw, I went into a room yesterday and this gal, man, didn't expect it, but man, was she aggravated. And that was nothing. I'm like, okay, yeah, she's got a valid argument. Let's have it. Oh. All right. Well, thank you for all your patience. And I will do my best to be just as patient with you guys. I think we should put the voiceover on and just let it go. So know that you can always listen to Jen's. That would be great.
I will say it is nice to have this voiceover.
Sure, because then you can go back through and listen and read. Which one do I want it in, people? Do I want it in Adobe? Do I want it in Firefox? You see what I mean? How it's making me do this? Do what?
Did you click download?
It was doing the same thing to me.
What's it doing to you?
Whenever I press download, it's downloading a blank document.
Yeah.
Anything is probably not good.
Yeah, just click.
The one with voiceover works though.
yeah,
Just maybe. Just maybe use this.
You want to
Just click that.
There we go.
Just maybe
All right, I
click
wanted to go to the.
this and then
Okay. All right. Get bonus points.
you have to use the arrow.
Okay. That I can try. Oh Lord. Yeah, I'm really in trouble. I love it. Yeah, exactly. That's why we're talking about this chapter. I got these that did added to my life not that long ago. I want to say within the last 3 years. So I've done pretty good. I didn't get the average age of 40. I did better than that. All right. So we've got the assessment of the eye and vision. Priority is sensory perception. When we're talking about senses, because we're going to do eyes and ears, right? remember that they each depend on each other. Okay, so you've got, how well is a person going to perceive you if they're blind? How well are they going to perceive you if they're deaf? You know, our taste, our smell. And our eyes opened up a bunch to this with COVID, right? People didn't realize how much they missed their smell, the smell of coffee, or the taste of coffee for those people. That's I think one of the biggest complaints I get is still people 6 months out, their food tastes like metal. Doesn't taste very good. But so sensory, keep in mind, if you lose one of your senses, we want to make sure you know that the others will pick up for it. You know, the blind person will know that somebody's walked across the room and from which side, and probably what kind of shoes they're wearing. You know, they will be able to perceive all that because that's their only input for knowledge on their surroundings. So I want you to keep in mind, senses, they're all going to be dependent upon each other. All right, A and P. Beautiful picture here, right? And you have this one in your book. All right, and we're going to talk about the 3 layers. Okay, and as we talk about the 3 layers, the outer layer is going to be your sclera, the nice white part of the eye, and the transparent cornea, that's our outer area, because we'll be talking about injuries to the cornea, because it's the outermost part. Okay, the mid area is going to be your uvea, and that one has the blood vessels in it, so it'll supply the nutrients to the retina. This area is heavily pigmented. The uvea also has the ciliary body. And what that piece does is it connects the iris, okay? And it connects it to the choroid tissue. So this ciliary body is going to be going around connecting. What the choroid does, it secretes the aqueous humor. Okay. The iris, which is the center, is going to be surrounding the pupil, but there's muscles in the iris that contract that pupil. That's where those are on. Okay, the innermost portion is the retina, and that is a very thin and delicate. Nothing else you'll hear of retinal tears, because it's very thin and delicate. And what it has is it has the photoreceptors in the retina, which they transmit that impulse to the optic nerve. Okay. And how they do that is with rods and cones. So you've heard of rods and cones. Rods are helpful with decreased light and peripheral vision. The cones do well in bright light, and they give us color and then central vision. The optic fundus, in other words, the optic disc, okay, that's where they form the optic nerve, and it exits the eyeball this way. All right. Nice other pictures. See all our muscles? If you count there, how many muscles do you have? 6 muscles. 6 different muscles, voluntary muscles that rotate and move the eyeball. I mean, we all want to be able to roll our eyes. I wanted to about 20 times today. You know, it's a great healthy motion for our body, but actually it's disrespectful, so we don't want to do that. But we do like to be able to have the motion available, okay? When we think about this, we have already talked about in our A&P class, our assessment lab, which cranial nerves do we think of when we're thinking of the eye? 2, 3, 4, and 6. Those are the cranial nerves. Okay, so that 2 is going to do what? Constrict, dilate. So we said 2 or 3, 4, and 6 is we're checking. But I want to let you know that cranial nerve 5, the trigeminal nerve, helps you blink. Okay, and then 7 does the lacrimal glands, and it also assists with the eyelid movement. So all those, you can tell a ton by the eyes. I want to let you know that light waves will pass through the cornea, okay? And they go through the aqueous humor, which we know is that nice clear fluid we have to have a lot of, through the lens of the eye, to the vitreous humor. The vitreous humor is real thick, okay? And on the way, then they go to the retina. So we've got that pathway of the cornea, aqueous humor, the lens, the vitreous humor, and it goes to the retina. And what happens when it gets to the retina? The structure bends or it refracts to the light waves. Okay, when we're talking about the other structures, as far as our cornea, it's nice and clear, and it's the external bump on the eye. The lens of the eye sits behind the iris, and it changes its curve to focus on near or distant. So the lens can actually change its curve for you to focus. Things we'll talk about later are the cataracts, because that's an opaque lens. And then, of course, glaucoma will affect this, and that's the increased pressure. Another part that you'll see is the canthus. Okay, it's where the 2 eyelids meet at the corner of the eye. And the other thing I want you to be aware of is the lacrimal gland. This is the upper outermost part, and lacrimal, what does that make you think of? The lacrimal duct, that's where you form tears. Okay? A lot of infants will have it that their lacrimal ducts are blocked. They're not open yet. They sometimes have to go in surgically and open those, because then they end up with a lot of exudate, yellow stuff, like stuff coming out of their eyes all the time. And it's because those tear ducts are not open. Okay, so the function of the eye itself, we have to have the refraction so that we can see, like we talked about the light waves bouncing off, right? So hemotropia, anybody in here have hemotropia? Woo! One. Does everybody else in here wear glasses or contacts? Anybody else in here with perfect vision? Wow. 20/20? You got 20/20? Then you've got hemotropia. Is it just the males in here that have hemotropia? You do too, Nadia? Wow, what a blessing. All right, so we have some with hemotropia. How about anybody with hyperopia? It doesn't refract enough light. This is farsightedness. Okay, so they can see things at a distance, but they have trouble seeing things up close. You're farsighted? So that is hyperopia. Okay, hyperopia. All right, anybody else like me? Myopia? Nearsightedness? Yes, so we can see things up close. We can't see them far away. All right, and then astigmatism. Anybody in here have astigmatism? And what? Anybody know what that means?
That's like the shape of the eye. It has to do with the shape of the instead of the eye being round, it would be like football shape kind of eye.
Or, yeah,
So
in
that
different,
would affect like refraction.
so astigmatisms are very common, but they're very hard to correct because it depends on where your shape is. You know, so has anybody not had an eye exam in here before? Like at an optometrist or ophthalmologist office? It's okay if you haven't, but wow. I mean, all the things they can do and see. All right, our pupillary constriction, meiosis, so constriction, meiosis and dilatation, mydriasis. Okay, we will need to know accommodation. Accommodation is important. You'll probably see that again. Accommodation is maintaining your clear vision, but the eye can accommodate because it can see distant, and as something appears or gets closer, like I said, the curvature of the lens will move, and it will accommodate and work so that everything is clear. Okay, convergence. Okay, so that's bringing those eyes. Can anybody do this? Take your finger out in front of you. Okay, and then let's just bring it in. All right, that's our convergence. All right, so we've got a pretty picture of a normal pupil all the way on the left. Okay, and the middle one is the meiosis, so you can see that the pupil's constricted, especially if there's a lot of light, it's going to be smaller. Dilate. All right, eye changes associated with aging. All right, this is going to hit home for me. Okay, associated with aging is reduced visual function. You'll see a lot of older people that they have to have light. You see me in clinical, what do I want to do? I want to turn on light so I can see things. Okay, and it's because you can't see, how much can you help? Do you want me to start your IV if I can't see your arm? You know, see where the needle's going? That was when I knew I needed cheaters with my contacts, because I look at that needle, I can say, well, is the bevel side up or not? Yeah, that's kind of a problem when you get ready to start an IV, so decided it was important not worrying these cheaters. Structural changes, decreased eye muscle tone. Okay, it's not going to be able to function as well, and we'll talk about that just in a second with the presbyopia. The ectropion and dry eye. In the older people, this is where the lower eyelid relaxes and it'll kind of fall away. So you've got, you know, you'll see this more often. And it'll kind of hang open a little bit. Okay? And dry eyes. A lot of people have to use a lot of eye drops just to keep it. I got a pretty picture of the arcus sinalis. We'll go into that further. As far as functional changes, the near point of vision increases. So typically, people can see if they're closer to it. The presbyopia is what I was talking about. Over 40 years in age is the loss of elasticity of the lens. So this is in our middle to older age people. So I can see, but then closer up, it takes me longer. So to see close up, I need these on. Okay? The far point of vision decreases. So we're not able to see as much out farther. General color perception decreases. Maybe that's why older people don't wear clothes that match. Or maybe it's because they just don't care anymore. I'm not sure. Okay, and then higher intraoptic pressure. Okay, and this is a big one, and we're going to go to glaucoma on this, but that can cause a lot of damage for your patients. Looky there. You see that? So there's an opaque bluish white ring within the outer edge of the cornea. The fatty deposits are causing trouble seeing in the dark. Beautiful picture, huh? Kind of reminds me, has anybody seen that movie, Young Frankenstein? Okay, forget that one. It's a comedy. All right, health promotion and maintenance. Those eyes just reminded me of Marty Python. Do you know him? Have you heard of him? Okay, that's one. Okay, health promotion and maintenance. What do we need to teach our people? Adequate nutrition. They need to have regular eye exams, especially after the age, so hopefully an eye exam in age 20 to 29. But we definitely need regular eye exams. Sunglasses, why do we need sunglasses? Do we just want cute ones? Or we want the ones with UV protection? For those rays, yes. Eye and head protection. And that's also just for all the skin cancers around. We want protection from the sun. Okay. If they have eye infections, they need to be checked immediately. And that is not something to wait. And the reason why is the sclera, the white part, and our cornea, that outermost part, they do not have a different blood supply than the rest of the eye. So if there's an infection out here, there's no way for that blood to get in there and fix it if we don't take care of it right away. So an eye infection can lead to blindness in them very quickly. Diabetes. What happens with diabetes? Okay, they constrict. Bottom line is they get tinier, more fragile. So there's not as much blood supply. Okay, and so a lot of diabetics have trouble with vision as well. They will lose their eyesight because there's not blood and oxygen-rich nutrients going to that area. Hypertension. What would that cause? Why is hypertension an issue? With the eye. The blood vessels, so they could burst if they, because those are your tiniest little vessels in the body. They could burst and cause problems and blindness. But also, the fact if it's going to increase the pressure in the eye, that can cause blindness. So we don't want pressure in the eye or throughout the whole body. All right, when we do our assessment, things we're going to notice and we want to ask about, of course, their age. What did I say? Over what age do we start to have presbyopia? 40. Okay, and so remember that's a generalization, so people that are 38 can start having that problem. Gender comes into place with a lot with their occupation. What are they doing? What kind of things do we have to think about as an occupational hazard for the eyes? Welders, so sparks, fire, anything like that. I'm sorry? I couldn't hear you. Chemicals. It's another sensory thing going bad. Chemicals, yes. Working on a computer a lot with all this training. Yes. Because we'll see if somebody's squinting or they're blinking a lot, or their eyes are tearing, or is there fatigue. There's a real obvious one I really want you to know. Who else is at risk with their eyes? Anybody care about nursing? Okay, and the reason why is because we don't want any fluids from those patients. Like if you think about COVID, what do we have to wear? The shields. We have to wear the extra eye protection. So yes, so the safety glasses to make sure that we don't get anything in. Okay, and leisure activities. I remember we had somebody come in with some burns, but they were just camping all weekend, and all they'd been doing is looking in that campfire, real close. Yeah. So even leisure activities can, or if they've been swimming and they were swimming in a pond, or they were fishing and got both capsized, and they ended up in the pond, they ended up with an eye infection. So depending on where the bacteria is. So we have to ask them about what kind of eye protection they use. If they have any other systemic health problems, and like I said, remember the blood vessels, there's not a whole lot there. So it can go to the eyes or the weakest part of the body when you have an infection. What kind of drugs they're on. I've seen some bone pupils and some heroin addicts, especially people that if they're doing any kind of drugs, if they're snorting, think about where that's close to. Okay? nutrition history. What do we want? Lots of beta carotene, right? What do we want to make sure that they have a good intake on their diet? Family history is a big one. And because that family history is going to tell us about diabetes, it's going to tell us about glaucoma. All right, things we're going to look. I mentioned a little bit at a physical assessment. If you're watching the patient, do they always turn their head to the left to read something? Do they turn it to the right if they're trying to see something? Or even on their phone, are they squinting? Is there symmetry between the eyes? Do they look the same? Their brows and lashes. What does that have to do with anything? If you're losing your eyebrows, see somebody that doesn't have eyebrows. I'm sorry?
It's supposed to protect from inflamming the eyes so you don't have that.
So it's a form of protection. Right. But you want to check their thyroid function also if they don't have eyebrows. Okay? If they're really thinning, you would want to check their thyroid. Let's see here. So we're going to do the sclera, corneal, and pupillary assessment, and actually do the visual testing. And we had it last week in lab, so does anybody remember what the chart with the big E is, what that's called? Because you'll see that in your charting. They'll talk about that. And then we had this nice little tool last week in our assessment lab, so it was about a card about a fourth of the size of this. And what it had, and instead of being 20 feet away, it had 18 inches away. And so you could also tell vision from that. All right, psychosocial assessment, anxiety, self-esteem, coping techniques. If somebody can't see, they're very, very anxious. Because it's scary. I mean, how are you going to see to step down? How are you going to see if somebody's coming from the side? It's a very scary thing. When people end up with cataracts and they're getting older and they can't see or they know they can't see, it's a scary thing. Okay? So hopefully we can get their eyesight adjusted so they don't have to deal with that. It does cause self-esteem issues. Who remembers, who was the youngest in here to wear glasses? I was 6. It was horrible. Anybody in here younger than 6? Having to wear glasses to school just stunk. Especially 3rd grade, man. I wanted to play basketball with the boys. And gym teacher said, no, you can't, you've got glasses. I said, no, we don't want to break your glasses. I didn't on anything. I took my glasses like this. I set them on the ground. Okay, I don't have any glasses. I got to play ball, that's right. I got to play basketball with the boys. But, I mean, it was not fun. So, they cause a lot of self-esteem issues. Even for me now. I don't have my glasses on at the moment, but I can tell you I brought them. I showed them to some of the clinical group yesterday. If I'm really tired, I can't put my contacts in. Today, I actually got some sleep last night. But, I mean, I cannot be without these. I usually won't leave the house without these, even if I have my contacts in. Because if something happens to my contacts, I won't be able to drive home. Okay? So, I will try to open my eyes briefly, but I want you to see the difference in my eyesight here, and then when I put my prescription on. Ready? Because I'm going to do it quick, because it feels crazy. Look at the difference in the size. See what I mean? So then, without my contacts on, can I even see it, put makeup on? Not at all. All right, so these are about -10. Pass these around, take a look through them, so you can see what I can see without my contacts, or without my glasses. I can tell you swimming lessons were horrible. So I grew up in this little town. You'd have to be pedaled out on your bike to the park, about a mile, 6:30 in the morning, catch the school bus, because there was not a pool in my hometown. We catch the school bus for a 30-minute ride, probably ride around 30 miles to this town that had a swimming pool. So we could get in the water at 8 o'clock. Man, you got to go swimming, but up northern Illinois is really cold, okay? So I'm getting in this water, we're excited, we're ready for swim lessons, and you can't have your glasses. So how could I see what the instructor was doing all I could do was kind of watch the kid beside me and hope they had it right so that I could see what to do to keep afloat. But yeah, you're in the water, and especially if it's deep, you want to know what to do. So you can see how it causes a ton of anxiety because it puts you in different situations that are very scary. So I bet nobody wants to try on my contacts, right? After seeing these? Did you take a peek through those? You saw them yesterday, yeah. So I mean, it is. It's a really scary thing. And it's a big deal if you've had to deal with glasses your whole life to be able to put contacts on. I did tell you some of them yesterday in clinical that when I first got contacts, 8th grade was the best thing ever. Except they didn't have soft contacts and they only had hard contact lenses, which they still have. Okay, but I'll tell you that when you got to try them on, you could only keep them in for 1 hour. And then the next day you got to keep them in for 2 hours. You added an hour every day until your contact usage up. Because at that point, with the hard lens, it was not allowing enough oxygen to get in. And so you had to make sure that the eye could form and it would work. So the first hour that I had my contacts in, I remember going to a venture store. You've probably never heard of those, right? Kind of like an elegant Walmart, okay? And I remember they had shoes, and I'm like, Mom, look at these shoes. They're just so big. Okay, she's like, what? I said, they're missized. All these shoes, there's no way I'd wear a size 7, and it would be this, that's just way too big for my foot. She didn't think much about it. And when I went home, the next day I got to put my contacts in for my 2 hours, and I pulled out the silverware drawer. And I looked at the silverware drawer, and that with my contacts in, the teaspoons, so my whole life everything's been smaller so I could see through my glasses, right? They looked like the size of the tablespoons. Okay? So it was amazing the difference because, and why does it do that? If you think about it, my glasses are here, right? And we're still talking the refractory and how it goes through. But if you get that lens right on, you know, it's much more exact. Same thing with, I love softball. Love to play sports. Softball, I was great at it. I was pitcher, catcher. I could do third base, second base, shortstop, but anything close and right, direct, right? Never first base. I'm not left-handed and I'm short, so that would never work. But what you have to think about is everything coming direct, I did fine with. I could never play the outfield until I got my contacts because you're going to lose the ball. If this is all I can actually see, there's no way you're going to lose that ball in the outfield. So when you think of somebody with poor eyesight, like myself and Darla, okay, hers is a different section than mine, but still with poor eyesight, think of it this, we depend on these glasses heavily. Your eyesight, big, big time. I think I've talked enough. I'm going to give you a little time, stand up and break, okay? And then we'll get back at it. Talk about self-esteem and the issues, coping techniques. How we're going to help these people cope better. Give them the tools they need. Make sure they have the light on in the room. What about their phones? If you have somebody that's impaired, you can make your print bigger and bigger. You can look for my mom for Christmas. I already picked up this last weekend. I was at a Christian bookstore and they had things to read the Bible easier. And it was a huge page-long magnifying glass, you know. And so it'll be big enough to sit on top of her music if she wants to learn new music on the piano, but also be helpful because she loves to read. She's an avid reader. But then it's just a page that can sit on the whole page. So make sure you help them with the tools that you have accessible to help them. Okay? Laboratory assessment. So yes, we will take cultures at times, and they usually get it just from the fluids and the conjunctival swab, so right in here. Imaging and assessment. If you're having vision problems, CT can tell a lot, MRI can tell the most, and an ultrasound of the retina and optic nerve. So talk about bright, those are very bright when you're sitting there. Other diagnostic tests are the slit lamp examination, corneal staining, so they will take, has anybody ever had that? Where they take, it looks like a piece of litmus paper and they go in and it's got stain and then it'll show if there's tears on the cornea itself. Tonometry, ophthalmoscopy, the fluorescein, angiography, the electroretinography, and the gonioscopy. These are not tests you're going to do. Now, maybe Maza, he's worked, have you done any of these tests before? Have you helped with which ones?
I did the corneal screening. Usually they use the fluorescein to do that. I've never done an angel test, but I use the fluorescein to do the screening.
Okay.
That's all. Well, I did the first one too. That's all.
Okay. So the thing is, he
The
didn't,
tonometry too.
okay, but he did all these, he was not a nurse, right? But he was trained to work in the optical area for the Navy. So he had training to use these, so you won't have to know these, but you will want to be aware of the fact that there are ways to do. IOP, what's that stand for? Interoscular pressure. You're going to need to know that, okay? The estimation. With this, he's taking the optician, and what it's going to do for this patient is she's all lined up. It's going to give you're going to feel a puff of air. Has anybody ever had that one done? Huh? Yep. And then,
What is the normal range?
you want, I want to say 22, under,
I think you go from
12 to 22. 12 to 22. Okay, and this you will see in the ER. You'll see this one at the doctor's office.
In the textbook it says 10 to 12.
10 to 20 for the textbook, 10 to 20. Other sources say 12 to 22, I know that. But this one, so they will do this and they will be moving the side. You guys have had this one done before, right? So they're looking at all of the sclera, they're looking at the iris, they're checking the dilation, they're checking to see if there's any tears. All right. You guys have the answers? Nurse caring for 4 patients. Which does the nurse identify that is at the greatest risk for developing vision disturbances? 29-year-old, history of diabetes, 50-year-old person working with computers. B, person with diabetes. 29-year-old is probably our least at risk, right? 50-year-old may just get the presbyopia where they just need to get the reading glasses would be the first thing you would expect to them. People working in the history of computers, yes, because it causes all that strain. Okay, question number 2. Which priority nursing intervention will the nurse provide when caring for an older patient who has problems with vision? What do you think? I mean, all 4 are decent, right? All 4 are decent answers. An older patient with problems with the vision. I would do B. Like I told you when I first came into the room. First thing I want to do is make sure I have enough light to see. So just think of your old instructor when you answer these questions, okay? You definitely know I'm blind, blind, blind. But all of them are good answers. But just the best before you even start to give that instruction for you, especially you want them to see something and make sure there's enough light. Okay, which nursing intervention best meets the psychosocial needs patient who has recently experienced vision changes? What do you think? go with C. Anybody disagree? We're gonna provide opportunities so they can give their concerns and about the changes, because they've gotta be made aware of them. They're not gonna know for certain if mom can do their ADLs for certain, until they give it some time and try. Okay, and have you already made adjustments in your lifestyle? One of the things that I can think that causes great anxiety for folks are people giving up their driver's license. You give up that vision, and it does cause quite a huge, now they're dependent on people. They're giving up their independence, and now they have to have somebody drive them everywhere. They can't go to the store, they can't, go anywhere they want to go without somebody else's help. And especially if they're still living on their own, that's hard for them, okay? To not be able to go, they can't go to the grocery store, get what they need, they can't go to the pharmacy, anything like that. All right. Any questions on this first part? There we go. I'm going to do the voiceover next. Okay. This one is pretty cool. This is a great picture right off the bat. You guys like that picture? You know what the picture is. Okay, this is the picture. You see all those diagonal lines? It's our stitches. That's a patient that's had a lens implant. So this should be chapter 42, right? Yeah, they are combined. All right, so this one starts. All right, with our cataracts on page 938 is where this basically goes to. All right, but yes, so that is where they have done a lens implant. Okay, we've got different eyelid disorders. So we're going to talk about blepharitis, inflamed, itchy, red, greasy scales on their brows. So you'll see it up here and on the lids. If you see this one, their eyelids or their lashes have stuff attached on them. Okay, entropion eyelid disorder, inward turning of the eyelid, and the lashes rub against the eye. So it's like taking your eyelid and then turning it in, so those lashes are poking in the eye. If they're poking in the eye all the time, you're not going to be able to keep your eye open. That one requires surgical correction. Okay, ectropion, outward turning of the lid, and that one also requires surgical correction. It's like Mazza pointed out, you no longer have the eyelashes. I wish I would have brought a, you will see them take like a Q-tip, like the wooden stick with a little bit of cotton, and they can kind of roll the eyelid one way or the other to show you this. But when they're doing their eye exam, they don't stick it in the eye. Do you understand what I'm saying? So they're setting it on top of the lid, then they're pulling the lid around it instead of just pulling it out. So this one also requires surgical correction. The hordelone, this is that's a nice name. Did I do something wrong? Okay. The hordelone, those are also, that's a nice word for a sty. Have you ever heard of people have styes in their eyes? And so what does that mean? Any idea? Like a bump or a redness, okay? And it is an infected hair follicle, bam. So it can be upper or lower. And what do we do for those people? I mean, it bothers them, it's sticking there, it's bothering them. The best thing you can do is a warm compress. So you're gonna take a washcloth, and you're gonna wring it out, make it warm. And the only thing is, do we wanna put the same thing back on and back on? Make sure you rinse it out, and then you fold it a different way. You get a different section each time that's on the eye, okay? Because, what is it? You don't want any increased risk for infection. Okay, chalazion is an inflammation of the sebaceous gland in the eye. And what are common approaches to care for eyelid disorders? What do we do if a patient has eyelid disorder? Who are we going to send them to? Surgeon, ophthalmologist? Definitely ophthalmologist to get started, because they can do, and they can do surgeries. That's the thing we have to have. Optometrists cannot do surgeries. Optometrists are going to deal with vision only, okay, diagnosis of cataracts, that type of thing, but an ophthalmologist can. Ophthalmic ointment. Okay, with this, I want to make sure you know how to put it in. Has anybody ever put in eye ointment? There is a chart in your book that has how to put it in. And I guess the biggest part of this is making sure that if there's an eye infection in one eye, you don't want it to spread to the other. So whenever you're putting things in, you're not going to touch, okay? You cannot touch the eye, so you have to do it above. And what you're going to do is then you're going to pull down gently, especially if you're teaching the patient themselves. First thing always is wash their hands. Pull down gently and start inside to outer with your ointment. In to outer. And this right underneath. Okay? But if you can do a right eye drop and a left eye drop, they're better. Here's a great picture of the blepharitis. Remember I said how that is just really scaly? And all you can do is keep wiping it out with warm soapy water to try and make sure you don't get it in the eye, but to get all that stuff out of the eyelashes. Because I don't think guys can relate to this, but gals, we put on mascara, we notice the difference just when we're looking out, right? I mean, when you first put on your mascara and you're just looking forward, do you see the difference? Okay, and then for the first time ever, at the wedding in California, I had fake eyelashes. I'm like, are you really, you want this old woman to be done? Okay. And I was like, okay. So I let them do it. But man, did I notice those things for quite a while. So you can imagine if you have these nice crusties on there, they're going to be in your way and they're going to see them. Okay, so the best we can do is wash them and get them out. All right, here's a nice picture of entropion versus ectropion. Okay, which one's which? Entropion, look at those eyelashes. On the left, they're going right in. See that? That's the one where he said we have to have surgery to fix that. The ectropion, be easy to put drops in there, wouldn't it? For ointment, that bottom part. But it's not going to take care of what we need. That also needs surgical repair. And there's our nice sty. They look nastier, and they're painful, but not hideously painful. Has anybody in here ever had one? Not fun. Oh no, gotta leave class. Sorry, fast. At least nobody's went off during the quiz, all right? We did all right? All right, looky there, Chalazion. Isn't that a beautiful picture? I'm so thankful that's not us. Okay, keratoconjunctivitis. This is the dry eye syndrome. So the issue with this, why are their eyes constantly dry? It is because there's changes in the tear composition. The lacrimal gland that I talked about, the lacrimal gland is where we get our tears, is not functioning correctly, and they have an altered tear distribution. Artificial tears is what we use as a regular basis. They will be prescribed by the physician. And this is one where we still don't want them to touch the eye, and they will need it for both. So they probably use one bottle, but always wash their hands first. Okay? And if it is bad enough, they can do surgery for it. Conjunctival hemorrhage. Okay, this is not fun. Hopefully it is a very small, well-defined area of bright red hemorrhage under the conjunctiva. People that have this are like really surprised. What do you mean something's wrong? Because they don't have any pain with it. No pain at all. There's no visual impairment. And usually the blood will absorb and will resolve in 14 days without treatment. So even though it looks really bad, it's not as bad. Here's our conjunctivitis. Look at all that nasty stuff. Okay, what's another name for conjunctivitis? Pink eye. What is this one? When I think about it, it's very highly contagious. So if they have it in one eye, do we expect it to go to the other eye if it's not maintained quickly? Especially if little kids are there rubbing their eyes. So the hardest thing is just to keep it minimized. Okay, and what do we use to treat conjunctivitis? Anybody know? Antibiotic. Yep. You gotta have it. Have the treatment. I know. My daughter doesn't let me forget. The one time I actually left, I left and with a girlfriend on a cruise, and I left her with a nanny. I was gone a whole 4 days. You know, first outing mom by herself after the divorce, and had these kids. And sure enough, what she did, she got pink eye. And she's like, I got sick while you were gone. She'll never again. So that doesn't happen when you're here, Mom. Sure. Okay. Trachoma, chronic bilateral scarring. And that's the thing to remember. It's scarring form of conjunctivitis. It's caused by what? Chlamydia. Chlamydia is not good on either end. Okay. Chief cause of preventable blindness. Okay, so we have to be able to, when I talked about treating eye infections quickly, this is why. Infection control is big. Corneal,
The silicone or antibiotic babies, if
They do, isn't that the trichomonas in case mom has, but they put it in immediately in the neonates, or as soon as the baby comes out. And we get them weighed and make sure you do their APGAR scores. Mom gets some time with them, skin to skin. Then the first thing one of them will do to make sure that everything's stable, then we'll put that in the eyes. I think we have up to 12 hours to get it in, but yes. To make yes, it's to make sure that we don't end up with an infection in their eyes that would cause blindness. And if it's easier to treat it than to not treat it, just in case. All right, corneal disorders. So we were talking about the cornea as the piece, your outermost portion, right? So it's going to be the one affected a lot of times. There are corneal abrasions, ulcerations, and infections. So an abrasion is just where it's been brushed and injured. But if you saw a corneal abrasion, you'll see the marks on the cornea. Corneal ulcer, I want you to think of even your wound care, the ulcers you see, how it just like eats away, all right? So that's what you're going to see, those spots more than a line, or like a corneal abrasion can come from a little kid. think of tiny babies and little people with their tiny, tiny little fingernails. You know, they're doing something, they reach up. So I've seen moms get corneal abrasions from that. I have a really ugly story about corneal abrasions that I had. I was in nursing school. I went out with my girlfriend, we finished class. I remember I'm wearing hard contacts, okay? Because we didn't have soft then. And we decided to go shopping. This is the same gal that was in California with me this last week. But we went shopping all day, and then we had figured it out later, all those clothing dyes. And I had my contacts in for almost 18 hours that day. You know, the night I woke up, excruciating pain in my eyes, had no idea what was going on. Tried to wake up my roommate, because I'm in the dorm, and it's like a U shape, you know, so there's like 10 rooms down here, and another 8 this way, and then another 10. And of course in the back, the last room, which came in handy very many times. But I couldn't wake up my roommate at all. So then I crawled all the way around because I couldn't stand up. I mean, I couldn't see. So it was just easier to crawl and feel and not worry about hitting anything. Crawled around all the way, and all the way at the top was my girlfriend Ange. I banged on her door. What? I said, Ange, this hurts so bad in my eyes. She's like, Mom, are you drunk or what? You know, I'm on all fours on the ground. I'm like, no, I haven't been anywhere since we were shopping together. And I said, I don't know what this is. We had not done eyes yet in nursing school. So she helped me, and she was beside me because I couldn't open my eyes, so I was blind. And she helped me across at Missouri Baptist over to the emergency. Okay? We're talking 3 o'clock in the morning. You know, but this pain woke me up. When I went to bed, I was fine. Well, it's so painful. They give you, I got Demerol and Visceral, which you don't hear a lot about anymore. But Demerol is also a form of morphine. And I was so happy to have a shot in my rear to get rid of that pain, okay? But back then the treatment, so then that's when I had to wear eye patches on both eyes. So I continued to be blind because the treatments didn't, well, they didn't heal well. The abrasions went to ulcers, and I wore eye patches for 2 weeks. 2 weeks. So how much, we're talking sensory, how much would you retain if you were sitting in class, okay? And all you could do is listen to the lecture. You can't read it in your book. You can't read anything in the textbook. You can't see what the teacher's putting up front. All you can do is listen. How much of this would you be able to study and remember? Probably about as much as I did. It was bad. I ended up, I was doing cardiac at the time, and we had a test on congestive heart failure, our midterm. And the midterm was a big question, and it was a big scenario you read. And you had left-sided heart failure, and you had right-sided heart failure. Okay? One was Mr. Smith, one was Mr. Jones. So the gal that read it to me was the secretary. And she only read that top part to me once. Okay? She wouldn't go back and reread it, because then you had all these questions on Mr. Smith and Mr. Jones. She only read it once, so guess who failed that midterm? Okay? Me. So they called me into the office. My eyes were better, you know, because I'm sitting there taking it blind. And they said, well, Sally, you didn't pass, and you probably just need to pack your bags and go home. Go home? No. I wouldn't go home. I said, I don't need to go home. And they said, well, you can't pass the rest of the semester. I said, oh yeah, I can. Let me have those numbers. I said, look, I have a 98% on everything from now to the rest of the semester. I get to stay. She looked at me and she said, you might as well pack your bags now. I said, no, I'll be here. And I was ornery enough. I was still there. So I do know that nursing school is hard. And, you know, at that moment, I really had to start studying. And I did, and I made it. You know, and each time, every test they took, okay, I could miss so many more, miss so many more. But yes, and you can make it through. But you don't think of all of that kind of stuff when you're going shopping. And all I did was wear my contacts. But to this day, if I go shopping, I can only wear my contacts, even with soft contacts, a short amount of time because I react to the chemicals and the clothing dyes. Now that's all hindsight. But you don't think of all the things external that go into the eye. Okay? So, all right. Other disorders, keratoconus and cataracts. We'll talk about cataracts a bunch. Okay. For cataracts, one of the things they're going to get is a corneal transplant. Okay? The cool thing about this is the deceased cornea is removed. So they take that first portion out, okay? Then a Butner graft of the donor cornea is removed with the same equipment, so the cuts are identical. And then the donor cornea is placed on the eye, and it's stitched into place with the suture material that is finer than a human hair. And we could see it originally on that first picture, okay? But hey, when you're saving people's eyesight, it's huge. Eye donation, corneal tissues come from our donors. Donors must be free of infectious disease or cancer at time of death. In the care of the potential eye donors at death, you have to elevate the head of the bed 30 degrees. So your patient has died, okay? You're going to elevate the head of the bed 30 degrees. They can have you apply antibiotic eye drops, they don't typically anymore. Okay, close the eyelids and apply a small ice pack. Now, I'm going to tell you, do you think, has anybody in here had a patient die out? 1, 2, 3. Okay. Did you do the care for the patient after they died? Anybody take care of the patient after they died? Because there's a lot to do with postmortem care. So let me tell you, if you just close that eyelid, is it going to stay down? No. You got time for one more fun story? Okay. First patient died on me. I'm a new nurse. I'm in GN. I haven't passed my board yet. I'm with another GN. Her name is Carmen. Carmen, love her dearly. Carmen was very, very dark black skin, okay? We had to go in, and there was 2 patients in the room. So the first one in the door was still alive, and had family there. And because we had not done postmortem care, we were sent in to this room, okay? We were sent in to get the body ready, put the toe tag on, get them bagged up, clean them up, the whole works. She's like, Belle, I don't know if I can do this. I don't know. I said, you got to put the right next, behind the curtain. You can do this, you can do this. And we're get the patient bathed, get them ready, we're getting them in the bag. I can't handle it. So she goes, she closes that eyelid, closes them both. And we're doing stuff, and then the eyelid pops open. Not right away, but then it popped open. And I saw a black girl turn white. I tell you, she was like this. Her hands, of course, were what? White. She was paranoid. She was screaming and running in place. You know, and her eyeballs were this big, and her mouth was all I could see was teeth and eyes, and her. She couldn't scream out loud because there's people right there. But oh my gosh! So just know, if you go to put those eyelids down, they are not going to stay. Okay. You can try it, but then what you have to do is put a little piece and then tape. Okay, just gentle paper tape. So yes. One of the things I want to tell you about corneal, or just about transplants and asking this donor information. Missouri Transplant Services comes, and you will give them the phone number after the death of the patient. You have to call the chaplain. You have to call your house supervisor. You have, of course, the family, if they're not there, you have to call them and notify them that the patient is dying. But if they're there, you're going to get their information, because then we also need a funeral home, because we need to know where the body's going to go. Or we, take it to the morgue. We're doing all this information before the body goes to the morgue. You can have it. Go ahead.
Student says if they have cancer, they have to be cancer-free. Does it matter what type of cancer, or is it just cancer period?
I think that's determined by them. We prefer to have no cancer, but sometimes, well, they prefer them to be free of HIV. Now, of course, they didn't want them at first with COVID at all. And cancer-free. They don't know, you have no idea if it's metastasized.
Yeah.
Okay.
My patient that I had, she had lung cancer, I think, and they were donating, her family wanted to donate her cornea. They were setting up
Corneas.
Mhm.
A lot of times they will use skin still,
Mhm.
and they will use bone. Remember we talked about bone-wise, I told you when I went to Missouri transplant and they had a big deep freeze, and I said, well, that's a bag of bones, and nobody laughed, but it's just about the size like this. You think as long as your femur is, depending on the person, all your bones in the body fit in it. But they grade those up, and they use them for spine surgeries, ear surgeries. So they can use bone all the time. They can use skin for skin grafts. Of course, the corneas. And then if you want to do an organ transplant, you can't let the patient die. We would at least keep their body alive, right, on ventilators, things like that, depending on what we needed to keep them alive. And then family would say goodbye, and then they take them directly to the OR, and they remove, and then usually the helicopter is right there ready to take whatever organ we're taking. If we're taking kidneys, or if we're taking livers, if we're taking lungs, if we're taking hearts, they've got to be ready to go. But all that has to be, there's a ton of prep work. So as soon as we know that patient's not going to survive, say they're brain dead, they're not going to survive, right? All that blood work has to go, and they'll be doing things to match with the person on the donor list. Who is their match? That donor has to get to the hospital, be ready. So if people say they're on the list to be a match, they usually have less than 48 hours, sometimes 24 hours to get to the hospital. So there's a lot of crucial things that have to happen for all that to work. So when it does, it's just amazing. And it really is amazing. So, anything else before I go on, since I got so tangented off? Sorry. All right, cataracts. This makes the eye cloudy and blurring of the lens. It's opaque. It makes it very difficult to see the retina. So you can almost see the cataracts as we're doing an eye exam. If you're looking, you'll see that opaque going over the top. Their visual acuity is restricted. It's not painful, and the eye is not red. A lot of people don't realize they're getting cataracts. But once they get them removed, they're like, oh, things are white again. Because everything gets a yellowish cast to it. They no longer see the bright whites of anything. Okay? They don't realize what they're not seeing. Sometimes it takes a car accident. Because they didn't see that other driver coming. My grandma didn't see a semi. You can't imagine, but she didn't. But it was because she had cataracts. She was very fortunate. She had a little tiny car. I don't know if anybody knows what an old Maverick grabber is. And she went to turn, and she was going, here was a semi going, and it caught her. She went right underneath in front of the back wheels. But she didn't see it. Found out left side, she had a cataract. Because she didn't see it at all. So yeah, talk about a thing that you think, how are you going to miss a semi truck? That's how you miss a semi truck. Here it is. You can see that clouded lens. You can see where they're going to take it off. Okay. So they use the sound waves and the suctioning probe. The sound waves break up the lens, and it's sucked out, and the capsule remains largely intact. This is very, very important, post-operative care. This is what you're going to have. might not have it as much unless you're working in outpatient, because these procedures are done outpatient. They're sent home right away. But you're going to have a neighbor. You're going to have a parent. You're going to have an instructor. You're going to have somebody that's going to need to have a cataracts. Okay, so with postoperative care, antibiotics are given. Okay, and so we're talking, they're going to be placing the eye drops, right? The eye is unpatched, and discharge usually occurs within 1 hour. You can imagine eye surgery. This thing, your cornea that's protected you your entire life, is now taken out and being replaced. But I remember when they used to stay in the hospital. Of course, they don't stay out for just 1 hour. Dark glasses are required. Why? They're going to be so photophobic, they're not going to be able to handle light. Dark glasses are required. And then we're going to instill antibiotic and steroid eye drops. I think you want to know that. You'll need antibiotics and steroid eye drops. Anybody want to repeat that? Then you'll need to know that. Okay. All right. Mild itching is normal. If they have pain, it's not a good thing. That means that there's some kind of contraindication, complication issue. So if there's pain, we need to call the doctor, okay? Because they should not have pain at all. Reduced optic pressure. So without that, it's not going to try as hard to see, so our pressures will go down. We have to prevent infection. That's why we're doing the antibiotics, and we're teaching them to keep their hands washed, keep them away from their eyes, and then we can check for bleeding. So which things do I want you to remember specifically off this page? Antibiotics and? Okay. And what's pain? What do we do? Call the physician. Big problem. Signs of complications: sharp, sudden pain in the eye. There's bleeding or increased discharge. The lid should not get really swollen, but if it is, that means we've got interstitial, there's a problem. It's not working correctly. If their vision decreases, their vision should be fine. And the numbness may be a tad blurry, but it'll take a little bit to refine it, but their vision should not be worse. And then flashes of light or floating shapes. Okay, they should not see any kind of floaters or flashing. Do not want that. We want to avoid activities that might increase their IOP. What would that be? What can you give me that would increase their optic pressure, ophthalmic pressure? High blood pressure, so keep that under control. Yes? Coughing. You don't want them to cough. You help them from coughing. What about, I'm sorry?
Flying, changing atmosphere.
If they were blind?
No, like flying.
Flying. Yes, you don't want them flying, any changes in the atmospheric pressure. Correct? Medication? Yeah, so they're going to look at their medications before. Well, we don't want them to have surgery if they have a cold, right? Because of the sneezing and coughing. All right? What about having a bowel movement, bearing down real hard? That's going to increase pressure. What about bending at the waist? Besides losing their dark glasses they have to wear. Okay, no, but that'll increase the pressure as well. So nothing strenuous, so they will, it's okay to be somewhat a couch potato during this time, so nothing strenuous, no coughing, no bearing down, no sneezing. And review the procedure for the use of eye drops. Has anyone found that in their book? It's in here. 941. Yep, that's activities that increase interocular pressure. No lifting objects more than 10 pounds. No sexual intercourse. Keep that head in a dependent position. And wearing tight shirt collars. Forgot that one. Okay, but there's also a page that has the use of eye drops. cannot find it right now. I'll find it before next week. See, I took a book and I've lost a nursing book. I know you guys are really sad. Somewhere between the airport in St. Louis and here, I've lost the one that I did all my notes on and stuff. So if anybody sees an extra soft second half of the textbook, let me know, please. All right, glaucoma. Let's go ahead and get started with glaucoma. All right. Except for I want to give one tangent. I am excited that I have the very beginning of the cataract. And you're saying, why am I so excited, right? Well, think of how bad my vision is. Okay? And I can only see 3 inches without my contacts or glasses. So I can't see an alarm clock in the night. Can't see unless I get my phone here without my contacts or glasses. But when my cataracts get to the point, and I only have one side that's starting, but it just mildly starting, but when they get bad enough that I can have surgery, I could have lens implants, and I'm hoping to be able to see without glasses or contacts. I'm looking forward to being able to read the clock on the wall, or to be able to see your faces normally. So, if you ever hear it, it seems kind of strange that people are looking forward to the cataracts, but that's the chance to get a lens implant. Otherwise, insurance companies, unless there's a medical reason, will not pay for a lens implant. What's
How
this?
hungry are you really? Because like whenever they do the laser surgery to fix your eyesight, you're awake.
Yes, you are awake.
So you're awake for that one too.
You are awake. Absolutely. Really strange, huh? It is. It's tough stuff. Would anybody be opposed if we started glaucoma next week instead of just getting started? You guys okay with that? Any questions on anything else eye-wise? Anything else about that quiz? Cause problems for staff? All of us? Hopefully that will still be a help to your grade. If nothing else, it's a help to hopefully so you know what to study, right? Kind of give you an idea. Those also all be like test questions on the final. So I hope to give you an update on what the quiz is next week, what our final scores. Just know nobody's score is going to go down. It's all going up. You just get at least another half point. Okay? So.
Your clothing stores for the guys, was it like looking different, or were like particles getting into your eye, particles from your eye?
They think it was just
Your reaction from
my reaction. You know, so like I said, if I go in a clothing store, now my contact lens, I can really, even with my glasses, if I shop with both, not like I do anymore, but if I'm in a store like 3 or 4 hours just looking at both, yes. So you've got to look at whatever kind of irritant. But that day, man, we was close by 6 or 7 hours. We shopped and shopped. And we had a rule. It was really fun. Of course, that was what, about size 7, yeah, about size 7. And Ange and I, we had different body shapes. Still do. Of course, mine is round, but I have, she always called me bubble butt, and I called her flat ass. So the rule was, she'd like, I don't have money, you have money. So the rule was, whatever clothing we bought had to fit both of us and look good on both of us. And then that expanded our wardrobe, because, you know, we lived in the same area, and yeah, we had a great time. But yeah, so, yeah, your crazy old instructor.